In this video, I will demonstrate an example of the assessment and treatment of the shoulder joint. I always examine the patient's shoulder even on return visits. First, I will ask the patient, please turn your back to us. Assessment of shoulder flexion. Observing the patient, I monitor not only the entire range of motion, but also the movement of the scapula, especially rotation, adduction, and elevation. Please raise your arms slowly upward. And during the movement, I observe the moment when the scapula starts to rotate and the maximum rotation achieved. Further examination of complex movement consists of internal rotation and extension. I will ask the patient to extend his arm backwards and place his hand between the shoulder blades. Always compare the movement with the other side. Another complex movement is flexion and external rotation. I ask the patient to put his hand behind his head between the shoulder blades. At end range of movement, I spring the scapula and I ask if there's any perceived discomfort or pain and compare it with the other side. Again, I will spring and I compare the range of movement at end field. I complete the examination of the shoulder girdle with orthopedic testing, especially if suspecting a slap lesion, instability or rotator cuff lesion. A variety of orthopedic tests offer basic screening, such as apprehension test, the O'Brien test, the speed test, or the Jorgensen's test for biceps lesions. Another test is arm elevation in the supine position. We ask the patient to slowly raise his arms to approximately 120 degrees of flexion. Observe not only the course of movement, but also the position and movement of the chest. If the chest rises during the movement, it means there may be limitations in the shoulder joint or a cranial shift of the chest. Next, we provide resistance in the testing position, push into flexion and monitor any chest movement, activation of the abdominal wall, the involvement of the shoulder girdle, and compare strength between the arms. We assess the shoulder girdle in the closed kinematic chain in quadruped position. Please come into all fours position on the mat. In this initial posture, assess the position of shoulder blades, hands, the entire arm, spine, chest, and pelvis. To test the patient, we ask him to lean forward on his hands. He rocks forward, bringing the shoulders in line with the tip of the fingers. Again, observe scapular stabilization and movement. The chest and the whole torso. In this case, we see that after a while, the right shoulder blade starts winging and the chest drops down. There's greater adduction of the scapula during the support function. Please return to your initial position. If we detect a shortening of the external rotators and the posterior deltoid, firstly we perform treatment in side-lying position to achieve eccentric activity of these muscles. The patient lies on his affected side, arm positioned with 90 degrees flexion at the shoulder. Forearm is lifted and the elbow in slight flexion. The patient is positioned directly on the shoulder. During the movement, he will shift the support towards his arm and at the same time pushing his forearm towards the table, performing extension and pronation of the forearm. Pushing the palm towards the table. At the same time, he rotates the trunk forward, lifting his head slightly, rotating the body approximately 30 degrees forward, still actively pushing his forearm into extension and pronation against resistance from the therapist. To complete the exercise, he rotates backwards. This achieves a lengthening of external rotators during eccentric activity. More intensive loading of the external rotators can be achieved in the side sitting position with forearm support. We call this oblique sit. The patient has support on the forearm and the elbow is placed under the shoulder. We fix the patient's humeral head and acromion manually, and the other hand guides the chest. We now guide the patient to a side-lying position. Slowly leaning backwards, the chest rotates forward and the palm rotates upwards. In this position, the external rotators and posterior deltoid muscles work in an eccentric activation pattern. The patient is in support on the elbow and on the forearm, lying backwards, pronating his forearm and rotating his torso forwards. Eccentric activity of the dorsal aspect of the arm and the external rotators occur. We will repeat this exercise several times. A more intense shoulder girdle loading can be performed in the bear position. We ask the patient to kneel into all fours, place hands underneath the shoulders, tucking the toes. We then ask for him to lift the knees and pelvis to reach above the shoulder level. In this position, we emphasize loading by pushing the scapula towards the palm support. We correct the scapular position and can also apply resistance from the front by gently pushing the patient backwards, and the patient resists actively. The next exercise will be performed in an open kinematic chain using a kettlebell. The patient is in supine and holds the kettlebell above the shoulder in a stable position, keeping the chest relaxed on the mat, focusing on feeling the connection of shoulder blade with the mat. Lifting the legs up, bringing the heels above the level of the knee, making sure knees are shoulder width apart. Inhaling a slight breath into the belly and now moving the legs to the side and to the other side, maintaining the arm and kettlebell in this position. We increase the difficulty by increasing the flexion in the shoulder. Make sure that the person is able to maintain a centrated position of the shoulder girdle and a neutral chest position. Breathing optimally allows the patient to maintain chest stability. Repeat this exercise several times. The next exercise is a movement against elastic resistance. The patient lies in a supine position and lifts the legs up. The elastic band is placed behind the knees and crossed in front of the thighs. The upper limb on the affected side is first lengthened into flexion position, hand is above the shoulder. We then guide the movement into diagonal abduction with external rotation. He stops in this position for a short while and then moves the arm into abduction, now returning the arm towards the trunk. Another supine exercise is to stabilize the shoulder joint, starting from a maximum shoulder flexion position. We perform it with both legs elevated. The elastic band is in a stretched position. The patient will bring the arm diagonally across the body towards the opposite hip joint. He maintains the chest relaxed on the mat. And please do this one more time. And then returning the arm into elevation, flexion, and adduction. The next exercise trains the movement from extension and external rotation into flexion and internal rotation. We will use high kneeling position for this exercise. The patient is kneeling, the left leg is supported on the foot, the right leg on the knee and shin. The patient turns his pelvis and chest forward. The movement begins with the rotation of the pelvis and chest, being followed by the arm movement into internal rotation and flexion. Before implementing active exercise, we always treat the soft tissues. We can use soft tissue techniques to stretch the fascia, not only in the shoulder girdle and arm area, but also the chest and pelvis. We continue the therapy with active exercise.